of multiple factors which we would be taking one by one. Being blessed with a normal ocular surface is really a blessing, and we realize this only when we sit in a dry eye clinic and we see the miseries of patients. And normally we also see that sometimes we do a very good cataract surgery, 6/6 vision, we are very happy, patient is happy, but after a few days the patient comes, radak ho rahi hai, takleef hai, maza nahi aaya, he's not happy. And we look for a number of reasons, and most of the time general ophthalmologists basically they get rid of them by giving lubricating eye drops. But what we should be careful is that not all ocular surface diseases or all such disorders are to be ruled out just by giving artificial eye drops. We should think of a normal ocular surface. You can see over here, this is a normal ocular surface with a shining light reflex showing that the epithelium as well as the tear film is normal. The conjunctiva, the limbal stem cells, the lid, the tear film, everything is to be normal. Normal layman considers, or a normal general ophthalmologist considers only the tear film as to be responsible for the ocular surface there, but there are multiple things we need to be take care of. Like in this picture, you can see we should have in mind all these disorders that can lead to ocular surface anomalies. The is this pointer working? The adenoviral conjunctivitis, which happens before, after, and during it, we have the ocular surface problems. The allergic conjunctivitis, asthenopic symptoms, canaliculitis, thyroid eye disease, contact lens disease. Second line beginning, you can see the lag of thalmos or the filamentary keratopathy, concretions, the aqueous dry eye disease, the blue film. Then you have this multiple use of drops with preservatives. Then you have this floppy eyelid syndrome. Some of the pictures you can see over here, this lid viper syndrome. Then you have this, ye chal nahi raha aapka? Chal raha hai? So we have this picture of Muhammad Ali where you can, such patients with Parkinsonism, they usually are very poor in blinking their eyes. They can sit before you for a few minutes and not blink their eyes. And there where the problem of ocular surface develops, various systemic diseases, acne rosacea, all these multiple things, they can lead to ocular surface problems. Now this DUS2 report that has standardized many things, but it has at the same time complicated also. Whenever we come across a patient having dry eye, we put them to a triage of questions. And if we find the answers positive, we can go for these OSDI questionnaires. And after the answers of these, we can go to the markers, the non-invasive, then the osmolarity, then ocular surface staining. Once these are also positive, we can conclude that he's suffering from dry eye. But then we have a spectrum on dry eye, the evaporative ones and the aqueous deficient ones. Again, we need to do a few investigations, the tear meniscus height and the meibomian gland diseases, which are nowadays more often labeled for this problem. So all these things, they are done, but all are instrument based. So and all obviously costly. So these this non-invasive BUT test, then the tear meniscus height test, then this infrared meibography for the lipid layer. All these tests, they are definitely machine dependent. The reports are there with us within minutes, but then they are all costly and are not possible for every patient. So let us listen to the patient and be firm about a clinical examination. We should ask about the duration, severity, progression, the initiating, aggravating, and the ameliorating factors, the diurnal variation, vision, treatment history, and systemic history. OSD as such is not a condition that will be cured 100%. It is a chronic disease and it has to be taken in. There are relapses and remissions, so we have to teach the patient like that. We should use these tests rationally, the BUT, Schirmer, and the lipid. All have their own, if all are normal. If only the Schirmer is decreased, we see that it is an aqueous dry eye disease, which is preclinical. If along with Schirmer, the BUT is involved, it becomes the clinical. Similarly, if the lipid problem is there, it is the evaporative dry eye disease, preclinical, and with BUT, it becomes the clinical. So we should be carefully using this and reaching to our inferences. And then we have to have a practical approach. The age of the patient, we know it's more or less a middle-age disease, but youngsters are nowadays also equally getting involved. Symptoms and signs generally often don't correlate. Then ocular staining should be done, and coexisting ocular conditions should be kept in mind and ruled out one by one. Systemic evaluation, again, many of the these autoimmune and rheumatic diseases are known to have these problems. The treatment mesh has to be considered, and keep reviewing the treatment and evolve long-term maintenance strategies. As I told you, the condition is going to remission and relapses, so we have to have the patient on long follow-up. We can follow this protocol of the routine investigation, the ESR and CRP to rule any chronic inflammatory, the RF and ANA, very common causes of dry eye, blood sugar, because many of these patients need steroids, so we should be knowing their diabetic status, the chest X-ray, urine, all for tuberculosis, and if you find dry mouth or other symptoms, the Jogren markers should also be ruled out. There are newer drugs available, few not in India, but chloroquine is there. Then there's another concept of true tears. When the afferent system is not responding or it is fatigued, the ocular surface is not involving, there are prongs available to, which are used in the nasal area to stimulate the secretors, and they stimulate the lacrimal gland, and true tears are kind of developed. These are moist chamber glasses, which are very commonly used for these patients. Then punctal plugs, these silicone plugs, wherever we're possible, we can just insert them into the punctum. They go deep and they help us to maintain the, avoid this overflow. Then again, another form of punctal occlusion is when a rectangular strip can be removed over the punctal area, and another strip from the fornix is taken and it is sutured over there, 4 corners are sutured with Vicryl, and over the time period, the punctum may get occluded. Then there's another concept of tear volume is to surface area ratio. Whenever we have certain conditions like this is a hereditary autoimmune disease which is not going to improve much the patient's cornea, the lateral tarsorrhaphy has been done to decrease the little bit of surface area so that the ratio can be maintained between the volume and surface. Now MGD is another reason for the evaporative type of dry eye disease. We ought to be aware of the normal anatomy. By clinical awareness daily, if you examine your patients, it is not always that you have to do a meibography to be knowing about the status of the meibomian gland. You can just evert the lid and have a look and you get a rough idea, because a meibomian gland, these streaks that are present are visible and they are responsible for the slow evaporation of tears and clear optical surface. This is a case of congenital absence of the meibomian gland, only one is present, and similarly the meibography will show this, NIBUT will show this test, the breakup time would decrease. Then this is the anatomy, the meibography that can be done. Then this is a spring-based device that is pressed over the lower lid in the middle area, and the secretions that come out from the meibomian gland, they help us to find out how the severity of the meibomian gland dysfunction. And then again, this infrared laser can be done to see the thickness. Normally when we press, a drop of fluid should come out, but if it is a spurt of fluid, it comes as out from the duct area, it is a seborrhea. Sometimes it is the toothpaste-like appearance that come out due to marked inflammation, the meibomitis, and sometimes it is so, even after excessive pressing, nothing comes out because they are atrophied and no secretion is there. That is the meibomian Sicca disease. There are other things, these cloudy appearance, all these changes during MGD, you see this frothy appearance in the lid margin. These are the collarettes and the Demodex disease which will come, MGD plus disease, the Clasion, corneal changes can be seen, and this is the Demodex blepharitis, we see on the lash lines. If it is a seborrhea, we get on staining, we get a short BUT dry eye disease. If it is a Sicca disease, we see this kind of picture because of the evaporative dry eye problem which is there. Further advanced inflammation due to meibomitis can lead to this kind of picture of flictenular keratoconjunctivitis, and later on the cornea may get involved and perforation can also occur, so one has to be careful. So while treating this MGD, we have to keep in mind the cause, whether it is the quantity of the secretions, whether the quality or the inflammation. If it is the quantity which is the problem, then warm compresses, lid margin scrubs and massage can be done. And nowadays LipiFlow is in there, half an hour massage is done and it is repeated in regular intervals. It is giving good results. If the quality is involved in these drugs, azithromycin, doxycycline and omega-3 fatty acids have been found to be helpful. Then there's this intense regulated pulse light therapy which is given, which again helps in improving the quality of the meibomian secretions. If inflammation is the cause, then again steroid, tear substitute and cyclosporin. So if we do not use this drug, the condition will deteriorate and corneal scarring, as you see in the last stage, can be there. So we should avoid these. Plus disease, Clasion has to be treated, Demodex with these treatment is there, and keratinization is also there, which can be treated initially if topical retinoic acid or even mucous membrane grafting may be needed. Papillae are another cause for these ocular surface diseases, giant papillae. They can also lead to shield ulcer, and so they have to be taken, they can be removed, as well as supratarsal injection can be given. Localized keratinization can be removed, but it again recurs. If it is just removed, we should use topical retinoic acid, and slowly after treatment it resolves. Lid margin, if it is keratinized, then the way out is the mucous membrane graft from the buccal mucosa. Using the fibrin glue and the sutures, we can put these mucous membrane graft for both the upper lid and the lower lid. It can be used. Then the another thing for OSD is the pterygium. This autograft is the best way to treat it. In primary pterygium, you may avoid reaching to the limbal stem cells, just free autograft can be taken. But if it is a recurrent pterygium, it is better to use from the limbal-based graft. Again, dermolipoma with limbal dermoid, another OSD problem, again can be treated. It is easily removed with a crescent knife, and AMT is very well used and gives good results. Then OSSN, another cause of ocular surface disease, interferon alpha 2b, known to give good results in very localized ones. However, if it is a diffuse one, the no-touch technique can be used, and AMT also, if needed, can be used. Lastly, we come to the limbus with the limbus stem cells. This is a case of chemical burn. We can see acute damage of the limbal stem cells. This is the normal eye. So wherever, this is another case where there's total deficiency. So limbal stem cell replacement has been done. We remove this pannus, and then from the normal eye, you can use the limbal stem cells from areas and implant it over there, and gradually it shows improvement. However, with Dr. Virendra Sangwan's and other from LV Prasad, this simple limbal epithelial transfer technique has also come up, where these limbal epithelial grafts are taken, and first the amniotic membrane is put over the pannus areas and deficient areas. Then these limbal grafts are put and over with fibrin glue and with the contact lens, and slowly these patients are known to recover. Allografts can also be used. So to sum up, whenever there's a dry eye dysfunctional tear syndrome, these are the first line, second line, starting from the tear drops and going to later on to the eyelid surgeries, wherever the causes can be found out. And finally, the take-home message would be since it is a disease of patients' expectations also, and education is a must, they should be knowing that it is a chronic disease that is not going to cure within days or completely cured at times. So long-term therapy for a chronic, has to be given for this disease. It minimizes worsening, and we should minimize the worsening and maximize the comfort and vision. Start with least expensive therapy, not already tried, and give patients hope and options for advanced care if needed.